Assalamualaikum and a very good afternoon to everyone who is zooming in today, and considering that it is a Saturday afternoon. So I am giving my hearts out to all the pals and cals who are tuning in today. And I want to thank you also to the organizing committee on the setting up of the MND Beyond Borders. And I hope that this endeavor will be very, very fruitful. I know, because they are very capable. All right, just for disclosure, I have nothing, no conflict of interest. The illustration or the gambars, photos of patients from UMMC as well as Regen, and may not all be PALs. And there will be a very short promotional video of rehabilitation and Regen at the end. So thank you so much to my good friend, Dr. Ichin, for the very kind introduction. I am currently working in Regen Rehab Hospital. I also serve as the medical advisor in terms of rehabilitation for MND Malaysia. And yes, I was assisting in setting up the MND multidisciplinary clinic together with, of course, Ichin and Professor Nortina. Okay, so for today's lecture, I will be sharing on rehabilitation in patient living with MND. I have got a very short time, so I will not be able to share everything. I'm just going to highlight what is important, and I use a lot of photos and visual. So for today, we will go very briefly on introduction, and then I will describe the rehabilitation team and role so that PALs and CALs can have a very good understanding of each team member. And then I will go on to describe the process and components of rehabilitation. And I will end by giving a case illustration of various stages of ALS with the rehabilitation management. So I would like all of you to just sit back and relax, and hopefully by the end of this talk, you will be able to gather not much, but at least some information on rehabilitation, inshallah. Motor neuron disease is a neurodegenerative disorder that is rare, but it's a serious condition. It is a condition that selectively affects motor system, of which the cell controls voluntary muscle of the body. So like what Dr. Ichin said, it has nothing to do with the oxygen, it has nothing to do with the lungs, but mainly the muscle. So it is estimated that in human, there are about 650 to 700 muscles, and muscles are very important for us to assist with movement, speaking, swallowing, as well as the breathing muscle. All right, so this is just a different type of MND, which I don't think I will go through. Okay, so this is the part of the brain where the motor neurons can be affected. So you have got the brainstem, as well as the saraf tunjang or the spinal cord. So depending on where the site of the motor neurons affected, the manifestation may differ. So the region of the body that is frequently affected, definitely most commonly we see the limbs, all right, the bulbar or the neck area for swallowing, and the respiratory. So definitely, if it's the limb, it will affect the movement or pergerakan, swallowing, pemakanan, and also pernafasan, which is the breathing. So now let's look, now we go into rehabilitation. What exactly is rehabilitation? Rehabilitation is actually a process, all right? It is not just one-off treatment, but it is a process of assisting patient to maximize function and quality of life after a certain health condition. So in this case, motor neuron disease. So although there is no curative treatment for ALS at this stage, rehabilitation is required at certain stages. Okay, so I'm just going to highlight some of the manifestation that we frequently see in motor neuron disease in rehabilitation. Okay, so first and foremost, they will present with muscle weakness, ya, otot yang lemah, spasticity, otot yang kejang, and they will complain of muscle stiffness, and this can give rise to a lot of discomfort and pain, difficulty with swallowing, what we term as dysphagia, difficulty with their speech, either it becomes softer, all right, or they have got a nasal voice, or we term as dysarthria. They may also have breathing issues at the late stage, can also where they can present with dyspnea. Some patients even come in complaining of not being able to think straight, where they have what we call as clouded thinking. So this may indicate that they may have problems with their cognitive or higher function, and sometimes they have got emotional ability. They have got some psychological issues with adjustment disorders that may lead to even a full blown depression. Okay, so if we look at this paper, we can see that weakness, of course, is the highest. It's almost the same as what we are seeing. Dysphagia, which is difficulty eating, dyspnea, pain, weight loss, and speech issues. So when we talk about giving rehabilitation management ataupun rawatan pemulihan, what exactly we are doing? Okay. So first, we need to manage the impairment and the disability. That means we have to harus berupaya untuk memberi rawatan ketidakupayaan yang dialami oleh pesakit MND. Okay. Number two, rehabilitation helps to reduce complication. So we do not want patient to be too early being confined to bed, what we call bedridden. We do not want them to have contractures. And of course, we want to avoid them having a lot of secretion that can lead to lung infection. We want to improve as much function as possible at par with their level of impairment. Okay. And rehabilitation is always goal directed and individualized. So you may have the same diagnosis, MND, but your treatment in terms of rehabilitation is not the same. So it depends on the disease impact and the natural history. So because the progression of ALS is quite fast, therefore it makes the prescribing of rehabilitation intervention quite difficult, challenging because of the rapidly changing functional status. So this is one of the biggest challenge in rehabilitation. Okay, in rehabilitation management also, we are involved in prescribing adaptive equipment to help patient. We prescribe autosis. We assess their activities of daily living. We look into their wheelchair prescription. Yeah, we also go to the extent of looking at their environmental modification to ensure universal access when they reach that stage, and provide cognitive rehabilitation. I will illustrate this with all as we go through the slides. Okay, so phases of rehab. Rehab starts very early. At least for us in UMMC, we get referrals very early. That's very good. And then once we get the patient, the process of rehabilitation will be evaluation. That means we do a detailed evaluation of their rehabilitation impairment. Then we set the goal, because if you remember, it is very individualized. And then we start giving the rehabilitation management. And then patients start to acquire the skills. And if needed, we may also do environmental modification. Okay, so MND patient goes through different stages in the course of their disease. Okay, so in view of rehabilitation medicine assessment, patient with MND should be considered a priority, and we need to assess them as early as possible, and we must offer regular monitoring and review. So I think in UMMC, we are doing that without much issue. Okay, so when we talk about stages of disease, we want to know, we want to understand a little bit what is the stages of disability. There's actually 6 stages. Stage 1, until stage 6. Okay, stage 6 is the worst stage. So 1 to 3 is where the patient are still able to walk, or what we call ambulate, and if they are stage 4 and above, they are not able to ambulate. All right, and their weakness will be categorized whether is it mild, moderate, or severe. Okay, so this level of disability is very important because it helps us to guide our rehabilitation management. Okay, so for PELS and CALS, you can look at which stage you are in for you to be able to source out the suitable rehabilitation management. Okay, so now I will go on to describe the rehabilitation team. So we have got the MND team, which has got the neurologist, palliative physician, the rehabilitation, but this is going to a little bit more detail into the rehabilitation team. So the team consists of the most important member is the patient. Okay, so you can see the patient is always the center of the team. And then you have got the physiotherapy, occupational therapy, speech therapy, the nurses, the dietitian, psychologists, the orthotic and prosthetic, and of course, you have got the rehabilitation doctor. Okay, so the rehab physician, we do the rehab medicine assessment, we identify the impairment, we look into the medical issues as they are doing the rehabilitation, and we prescribe the rehabilitation management for the MND patient. The rehabilitation nurses, they are the one who specialize in giving rehabilitation nursing. They provide the care of the patient 24 hours if needed. They are the one who are able and capable of training the bladder and the bowel if needed. And they are the one who will advise and look into the skin integrity, prevention of pressure sore, and if there's any wound, they will be involved in the wound care. The rehab nurses also would educate all patients and carers regarding fall education and all the medication that is being prescribed. The next team member is the occupational therapist. The occupational therapist is the one who would train patient on their day-to-day skill. Okay, so they do an in-depth functional assessment. They do the functional retraining. They are also involved in cognitive rehabilitation. We do get a fair bit of MND patients who are still in the productive age group where they need to return to work. So the OTs do a detailed assessment of their return to work program, ergonomics, okay? So they are also involved in wheelchair assessment, and they do the planning for any domestic and community activities. Okay, okay, physiotherapists. Physiotherapists are the one who address the physical aspect of the patient. Okay, so they are the one who train the patient's mobility, sitting, standing, lying down. Okay, so they are the one to help patient to train their gait training or walking training. They will be the one who would deliver the muscle strengthening, muscle stretching education, and provide the exercise per se to the patient. They will do the respiratory therapy. They will do the physical modalities. And for those patients who are treating MND, at least in PPUM as well as in Regen, they usually would have some advanced neuro rehab therapy knowledge. Speech therapies are involved in assessing the swallowing aspect of the patient. They are the one who is certified and trained for all communication disorders. They can also suggest augmentation and alternative communication. They are also able to evaluate using fiber optic endoscopic evaluation of swallowing. Okay. All right. So let's look at the first case. Okay, so I have with me this patient who is still early in the stage of the ALS. So it's either stage 1 or stage 2 because he's still able to ambulate. And his problem when he came to us was he was having frequent fall, unsteady walking, and feeling weak. So let's have a look at his video. So the abnormal side is the right side. So you can see that he has got difficulty lifting his right foot. He is having to excessively bend and flex his knees and his hip. So he uses a lot of energy. So a patient like this, they are prone to fall. So we diagnose to have foot drop. Okay, so what is important? The exercise and everything. We have to prescribe him with an ankle foot orthosis. So the ankle foot orthosis will help to neutralize the ankle joint. So we can see him sitting with AFO. So you can see that his gait is more stable. He can lift up his foot on the right side, and he will use less energy. All right. So before prescribing with any orthosis, we definitely need to train them first to make sure that whether they need to use any gait aids, right? So this is where the physiotherapist will do the training, right? The other orthosis that is useful for our MND when they have got head drop syndrome, where their neck muscle are pretty weak, will be what we call a headmaster orthosis. So this is not as rigid as a hard collar. It has got soft cushioning, all right? And I have actually requested for them to procure this orthosis, and we should be able to get it soon, in a couple of weeks' time in UMMC, and it should be in the range of, I'm not quite sure, but it should not be so expensive. It will be less than 500 ringgit, I was told. Okay, so this is our second case, moderate stage. That means either stage 3 towards stage 4, whereby the patient is already complaining of difficulty in walking and transferring, already having a lot of pain and discomfort because of the stiffness, as well as back pain. Speech was becoming more difficult, already having swallowing issues, nutritionally not sufficient, and overall deterioration in function. Okay. All right. So this is the late patient. All right. So this is where the physical modalities come into play. And if you are handling with anti-gravity muscle, we have got to try to support the muscle so that they can still do passive range of motion. I will go into detail each type of exercise later on. So any discomfort, we can start off with some heat therapy. This is using wax, which is quite easy and straightforward. And this is doing two activities at one time, which is gait training as well as balance and coordination. Okay, so you can see the cubes on the floor. That is to give him coordination and some balance. So for this patient, we need a little bit more management. We need to look into the musculoskeletal rehabilitation. We need to already start the dysphagia management, introduce him to low technology of AAC. Definitely need to already assess and advise carer and provide as much emotional support as we can. Okay, next patient, as you can see, patient with involvement of the left hand. You can see the wasting of the intrinsic muscles of the hand. That means all the little muscles of the hand. You can see the tena, the hypotena, right? Compared to the right side, this is the wasting. Okay, so then this patient, they will have problem with hand grip. So you can prescribe this cuff. It's called a universal cuff. It can help patient to still participate in activities like feeding. All right, feeding, grooming using this universal cuff. It is very easy to make, all right, and it's not expensive at all. Okay, so this patient also having intrinsic muscle weakness, whereby not able to grip. So you can just use rubber band, a very simple gadget, to try to assist with writing. Okay. If they are more advanced, whereby their muscles are more wasted, especially the intrinsic and extrinsic muscle, that means otot tangan dan juga otot di bahagian arm. So we need to consider giving splints to prevent contracture. Okay, because otherwise they can go into contracture, and that's going to cause them more difficulty in doing their activities of daily living. Okay, and then we must also pay attention to continuously doing fine motor activities. Yeah, fine motor using the small muscles, the lumbricals, the intrinsic muscles, and couple that with functional task-specific activities. Okay. Okay, this is an example of patient being trained to use fine motor skill and task-specific activities. Because there's no point in just doing passive if they're not able to translate that into functional and task-specific activities. Okay. Our last patient is a patient who is quite advanced in the disease, and this is where they are ready for counseling in terms of wheelchair assessment. Because most patients, they try to delay as much as possible because sometimes they feel that it is a stigma to be using a wheelchair. So we need to assess them because sometimes it will be much easier to provide them in terms of mobility for wheelchairs. All right. So this is the late Stephen Hawkins. You can see how fancy his wheelchair is with a lot of gadgets. So there are actually many types of wheelchairs. All right. So we need to see the right wheelchairs. So the thing that will help you to decide would be the patient's condition. What are the indication for the wheelchairs? What are the type? What are the size? What are the requirement? What are the function of the wheelchairs? All right. You need to suit the size of the patient so that it can fit them nicely. All right. And it's safe for them to use. And now there's even this thing called standing wheelchairs. And the good thing is that the technology is quite readily available. Hence, the cost has reduced tremendously. Okay, so you can get standing wheelchairs like previously would be about 60,000. Now it will be like 16 to 20,000. Okay, so the type of wheelchairs that is suitable for MND, definitely they would need a tilt-in space because you can actually tilt them with the reclining. They may also need a tabletop for them to be using like an eye tracker. They may be a powered wheelchair because they don't need to manually move or push their wheelchair. And in the case where they need to go to hospital, where it is too bulky to bring in the wheelchair, you can just resort to having a push chair. So you can see that this is actually a very simple wheelchair. The tires are quite small and it is much lighter for the carer to actually handle. Okay, so these are the different types of wheelchair. And then we look at how to facilitate transfer. That means transfer from wheelchair to chair, wheelchair to chair to the car, for example, to the bed. So there are a few items that we can assist. For example, using a firm cushion, because if you elevate a little bit between the hips, that will make it easier for them to transfer. You can also use sliding board, but this is with the condition that the upper limb is still good. Or in the case where it's very advanced, you may have to use a mechanical lift. All right, I will show you. So this is a patient where we have to train the carer how to do a car transfer. Okay, if the patient can stand, it is not difficult. But if they are no longer able to stand, that's where we need to ensure a safe transfer technique. Because they have to come to hospital, you know, they have to go for their visit, right? So you need to teach them a proper technique. Also to the carer, so that it will not be a burden for them. Okay. This is what I mean by sliding, using a sliding board. And this is using hoist or mechanical lift. Okay. Patient needs to be informed. Okay. She's quite happy. Okay. You need to also see the suitability of the carer and the patient when you want to give them a hoist to be used at home. Okay. All right. So I'm going to talk a little bit about difficulty swallowing. Okay. Masalah penelanan. So when they have got weakness of their bulbar muscle, they can have weakness, difficulty in chewing and swallowing. They can also have problems with drooling of their saliva, coughing, and all this can lead to aspiration and malnutrition. And this is not good because then it will be a negative prognostic factor for the patient. Okay. So there are three phases of swallowing. All right. You have got the oral phase, you have got the pharyngeal phase, you have got the esophageal phase. So we need to assess which phase they would be having, all right, when we assess the patient. And these are some of the dysphagia management. You can either start modifying their diet, yeah, improve in their sitting and positioning when they are feeding. Definitely, you must start oral mastication, muscle movement, and therapy. And of course, if the situation requires, then you got to start counseling for tube feeding. Okay. So as you can see, there are different types of food from regular, soft, mince and moist, pureed, and a fully liquid diet like milk. All right. Similarly, with drinks, you can adjust the thickness by using thickener. This is some of the variation of oromotor activities, yeah, to work with your oral motor mastication, because you have got your facial muscle, you have got your mastication muscle that you need to teach them how to exercise so that they can actually eat their food. Okay, so this is speech therapists doing articulation activities. So you can see the patient is tilting his head and also doing extension. Right?
And down. Down some more. Okay, 1, 2, 3, 4, 5, 6.
All right, so this is doing swallowing assessment. We auscultate for gurgling, right? This is a clinical bedside to ensure that there's no penetration.
Nothing.
Okay. And we can also do FEES, which is fiber optic endoscopic evaluation of swallowing. This is to see the pharyngeal phase of the swallowing. All right. So it is quite straightforward. You can also do this by the bedside. So for the other impairment, which is difficulty speaking, dysarthria can manifest as one of the presenting symptoms of ALS. Again, oral motor exercise must be given because it can improve their ability to communicate. And if the patient has already not able to have functional communication, that's where you need to get some compensatory speech technique to improve communication or start to consider AAC. Okay, so we always start to use low technology and not always high technology first. Okay, something that is easy for the patient according to their level of comfort, their comfort level of using technology. Okay, the next thing, exercise. I get quite a lot of question. Can exercise, is it safe for motor neuron disease? Because it's a muscle, it is involving the muscle, kan? And whether it helps to slow down the disease and what type of exercise is suitable. So there are already some research being done to say that exercise, if given during the early phase, can help to delay the progression of the impairment. Okay, and it is recommended moderate intensity exercise can help to improve function. Okay, I will go through each one. So the first type of exercise is strengthening. Strengthening is when you are using repeated muscle action against resistance. And the benefit of strengthening in MND, it has got the potential role in maintaining the muscle strength and delay the onset of functional impairment. Okay, so this is a simple way of doing strengthening. Okay, so the precaution of it is to avoid high resistance. We must find weights or resistance that the patient can do comfortably for 20 times, 20 reps. The progression to use heavier load or heavier strength depends on the stage. Like I said, stage 1, stage 2 to stage 6. And we must try to avoid muscle that do not have anti-gravity movement. The next exercise is flexibility or range of motion. Okay, so this is what we mean by range of motion. It is doing stretching to ensure to maintain the range of motion. So range of motion is part of the standard care to prevent complications such as contractures. It also helps to reduce pain and spasticity, especially for patients with MND, with upper motor neuron, where they have got a lot of stiffness. All right. So the caution is that we must encourage regular stretching and ROM during the early phase or early stage of the disease. The caregivers need to be trained because sometimes their participation is required in the advanced stage where the muscle weakness is so dominant that the patient is not able to do. But range of motion needs to be done all throughout the stages of the disease, to prevent contractures. The third type is balance. Okay, balance training is very important, and you need to use different modalities. Like just now, you saw the cube on the floor, and because if you are walking but you do not have balance, this is potential recipe for fall. All right, so you must have balance training because it serves as a basis of maintaining ambulatory status. Okay, so this is our physiotherapist doing sit to stand, but it helps to do balance because you need to keep both legs on the floor. Okay, so for MND patient, you must perform under supervision of physiotherapist first. All right, the last exercise is aerobic. Aerobic is when you use dynamic activity using large muscle group. So aerobic has the potential of reducing deconditioning, help with the endurance, and also still maintaining functional independence. So you can use gadgets like overground gait training like this for patients. You can use treadmills. You can use recumbent bike. Okay. Right. So you need to just, for MND patient, you must just do it at sub maximal level. All right. And you just start with about 10 minutes and you need to select which type so that you can minimal the risk of injury. Is exercise safe for PELS then? The answer is yes. Okay. If you follow a specific precaution. Okay, so you can go into this website. It gives you 7 tips for starting exercise program for ALS. I find it very, very useful. So all the PELs and KELs can definitely go to this website. Okay. All right, so we actually have a book to share with our patient on all the exercise that I have mentioned earlier on. It's actually in the rehab department in PPUM. Okay, Last we look at respiratory problem. I think this has been covered, but just quickly, patient, they can present with a lot of issues, but for us, we want to make sure that there's a lot of less secretion and to maintain their inspiratory muscle and expiratory muscle effort, as well as their secretion management. So that will be the rehab goal. Again, to monitor the signs of respiratory insufficiency, the list just now, to always maintain cough and airway secretion management, and to do respiratory muscle training. So I'm sure all of you are familiar with our incentive spirometry, whereby you need to give them this so that they can have, this is part of the training of respiratory muscle, where you inhale through and see all the balls raising. So this is quite a good feedback for the patient to work on their inspiratory muscle. Okay. Coughing is very important, okay, because it is part of mobilizing the secretion. And there's actually 4 phases of coughing, where you have got the irritation, followed by collecting the air in your lung through the inspiration. And this is where you have got the air trap, where you have got the glottic closure, the compression, and then the expulsion of the cough. So when the patient cannot do this, there are various methods that you can tell them, teach them. For example, you can do unassisted breath stacking, or you can do lung volume recruitment to try to give them more volume in the lung. And of course, lastly, if you ventilator or MIE, okay? All right. So these are the benefit of breath stacking. You have to increase the cough peak flow and maintain the insufflation. That means the inspiratory ability. Okay, mobilize the secretion. Okay, so this is a video of teaching how to do breath stacking.
I will be teaching you how to do breath stacking ataupun kita panggil pernafasan bertingkat. This is one way to help with coughing. Alright? Okay, so what I need you to do is I need you to take a deep breath in as much as you can and try to hold and release. Okay. So breath taking means you need to do 2 to 3 times breathing, alright, and stack up the air so that we can collect the volume of the air in the lung. We try to have a much better expulsion. So what we need to do is take in a deep breath and then continue to take another breath and then continue to take another breath and then you try to cough. Okay, let's try it again. Breathe in. One more time. Okay. Okay.
Okay, so this is showing the lung volume recruitment.
Another technique of breath stacking, and this technique will be useful for those who doesn't have enough strength to cough out. That means they have a problem with the inspiratory or the breathing muscle. So we'll be helping them mechanically using this ambient bag. Alright? So this technique is called lung volume recruitment. So what we tell you to do is first you will put this face mask and have a good seal with your mouth because sometimes you're not able to seal it well. You take a deep breath, alright? And then you try to introduce the air by pressing on this empty bag, okay, to give you more volume in the lungs. Breathe in. Then you try to cough out. Okay. Let's do it one more time. Okay, so you please breathe out as much as possible first. Okay, right? In. No, first you breathe in first as much as you can. Hold. Okay, one more time. Okay, and okay. I'm going to demo.
Okay, so this is another method where you don't use the mouthpiece, right? Okay, so if in the worst case scenario, you got to depend on mechanical in and exhalator to try to help the secretion to be mobilized. Okay. Okay, so those are the most common type of impairment. But just quickly for pain and fatigue, I just have one slide. This is energy conservative strategy. Just remember the 4 P's. Okay, that means how you want to conserve energy. Number 1, priority. Always prioritize your activity. Number 2, plan ahead what you want to do during that day. Number 3, you must pace yourself. And number 4, it's always important to adopt good posture, even when you are sitting in the wheelchair, because you can use 25% less energy. It has been shown when you sit with a proper posture, even in the wheelchair. Okay. All right, so we know that motor neuron disease, it gives rise to a lot of impairments, but nevertheless, there are a lot of approaches, techniques, equipments that can help to facilitate and maintain one's function. Okay, so this is just a category of equipment that I've mentioned. Number 1, transfer devices, mobility devices, orthoses, ADL equipment, assisted technology, speech devices, and home modification. Okay. So to summarize, we know that MND is associated with dysfunction of the motor neurons and is a very heterogeneous clinical spectrum. Rehabilitation strategies are tailored to individual depending on the stage, the 6 stages, and treatment strategies are generally aimed to reduce the impact of the MND. That means to help with the impairment, care, and to maintain quality of life. Okay, so with that, just sharing some. I have got one last video. I hope I have time. All right. So this is what we do in our hospital.